Good evening, everyone. How are you all? Sorry for the delay today. We just had a little bit of difficulty with another trial class for the MCQ, so I had to go there. Hopefully, this is fine now. We can start. So, how are you all doing? Tonight, we are going to do some role play, right? And we also wanted to finish a little bit that we have left in cardiology class, which is basically the cardiovascular risk assessment question. Okay, before we start, we just need to share the screen with the Facebook as well. So just give me a moment and then we will start. Okay, so let's start our tonight's session with cardiology role play session. So you must have got an idea that how we do the role plays and also how the cases come in the exam. And you also had some random role play session with Dr. Cynthia, right? How did you do with that? Did you like the class? Did you get to understand that how random cases can appear in the exam and how to deal with that? You must have also learned from our ex-students because they also join those sessions just to do role play with us. And sometimes they also help other students. So you must have learned from them as well. Did you like the class? Okay, now, as you know that this is almost the end of our first 2 weeks free session. We just have another 2 sessions left. After today, tomorrow, there will be another random role play session. So we have asked Dr. Cynthia to share what are the cases she's going to do tomorrow. And that's mainly, we don't share this in our official group, but it will be shared in our course group. So those of you who already joined, you should be able to know that what are the cases that she is going to discuss. And also, we have another pediatrics vomiting cluster to finish with. And after that, we will start with our course in the full rhythm. And the plan is to start with an orientation class. If we finish the 2-week sessions on 17th of May, so just the next class after 17th of May, that will be on 20th of May. So 20th of May will be the orientation class for this course. Now, the orientation class is one of the most important class because we discuss each and everything about this exam. And also we discuss about how to actually appear the exam, what are the things that you should have, how to do the preparation fully. We also do a walkthrough into the portal so that you understand how to get the best out of the portal and how you can prepare in between the classes. Because this is a 5 months course, you will have a lot of time in between the class, but don't think that you will get a huge amount of time. But the time that you get, you are supposed to utilize that. And we have a lot of things to offer from the portal so that you can also involve yourself with those and get to learn about the exam in a well-organized way. Okay, so in the orientation class, we are going to go through each and everything. So if any of you who want to join the course, I would strongly advise to finish doing that before 20th of May, because after that, there will be no orientation class. If you join in the middle, we always allow that, but it becomes a little bit confusing for you because you just start in the middle. You don't have any idea what's going on. And it is not a standard way of doing this course. We always encourage everyone to start from the beginning of the course because that helps a lot. Okay, so what's the plan today is that we do some role play. The role play focus will be on both online and face-to-face exam, but mostly online exam because online is much more available nowadays, as you can see. And any of you who wants to do the role play, you can come and just say that you want to do role play, and we'll try to accommodate you. We always encourage people who haven't done role play in the previous few role play sessions, come forward to do it today so that everyone else gets some chance to do this role play. If the same person do the role play multiple times, that doesn't help everyone. We always encourage new candidates to do the role play. So if any of you who has done role play with me with the MSc role play session, please don't come forward immediately. Allow the others who haven't done any role play with us yet. And then once the course starts, again, you can start doing the role play with us. So there will be enough time and enough way to do role play if you actually want to. All right, and those of you who are in Facebook, role play sessions, joining it in the Facebook doesn't make any sense because you can't do role play with us if you are joining from Facebook. So I would say that just 14 of you are there. Just come to the Zoom, and then in that way, I don't also need to look onto the Facebook time to time, and you can also do the role play with us. Okay, all good. Let's start then. Who wants to do the first role play? Dr. Zahra, okay. Dr. Zahra, can you unmute yourself?
Okay.
Hi, Dr. Zahra, how are you?
Just thank you. How are you?
I'm good, thank you. Your sound is coming a little bit like not very clear. Can you check again, like say something to me?
Yeah, that's a bit good.
Yeah, it's a bit good. Yeah, it's a little bit like not very clear, but maybe it will become clear when you do the role play.
Yeah, just a second, please.
Are you using a headphone or anything like that? Dear, are you using any headphone?
Is that better?
Yes, now it's really good. Okay. Now, for the purpose of role play, always remember that it's not always that something that we have discussed in the class, it will always be the same thing. There's a lot of noise coming up.
Can you hear me,
Zahra,
doctor?
there is a lot of noise coming up from your end.
A lot of noise. Just a second, sorry.
Yeah.
Is it more? Is it better?
Yeah. Do you like, because it's a role play, Dr. Zahra, if you just want to come to any separate room and just do the role play with us, because I can see your, like some people is back in your background. So that will be much easier for us to see you. Yeah.
Yeah. Yes, sure.
Okay, now it's really good. Thank you. Okay. Let me give you the case just in a bit.
Sorry?
Let me give you the case now.
Yeah, sure.
Okay, so this is your case. Your 1 minute time is started, and you will get 7 minutes 30 seconds to do this role play.
Yes.
Okay, so this is your patient. Your patient name is John. You can start.
Yes. Hello, John. This is Dr. Zara. I am one of the doctors here in the clinic. I hear that you have recurrent falls for 2 consecutive nights. I'm so sorry for what happened. I want to be sure that I'll take care of you. So can you tell me more about what happened?
Yeah, doctor. So for the last 2 consecutive nights, like whenever I am trying to get up, usually at the middle of the night to pass urine, I just feel like I feel a little bit dizzy, and also sometimes I fall. And this is just very new for me because it never happened. I'm usually well steady on my feet, but just for the last 2 nights it's happening.
Yes. Is it happened suddenly or gradually? Did you feel any headache or dizziness before it happened?
No, it just happened very suddenly whenever, like, because I just get up from my sleep because I need to go to the toilet. And this is also new that I feel like I'm going to the toilet more than usual. And whenever I get up, because I'm just sleepy at that time, so I try to get up early, like very fast. And then suddenly I feel very dizzy. And the last 2 nights, I even have a fall.
Yes, okay. So do you have any other symptoms like shortening of breath or chest pain?
No?
Good. Do you have a fever or any rash in your body?
No?
So did you feel every time you get from bed, you feel dizzy or headache, anything?
No, doctor.
Okay, good. Okay. What about do you feel like joint pain these days? Do you have any joint pain?
Yeah, doctor, I'm in the 70s. There is some pain, but I live with that.
Yes. So what about the condition of your home? There are poor lights or loose carpets?
No, it's usually good.
Yeah, good. Do you feel stressed these days? Or in stress at work or at home?
No.
No, good. Do you have about did you have any change in your bowel habits?
No.
Any change or your weather preferences?
No.
Yeah, good. So, do you have a diabetes mellitus, hypertension, any heart disease?
No, doctor.
Yeah, good. So, are you smoking or drink alcohol?
No, doctor.
Yeah, good. Are you in a medication?
Yeah, doctor, I take some multivitamins and also aspirin. That's it.
Yeah. What is the cause of you take aspirin? Why do you take aspirin?
Just to like one of my GP recommended me that after 50, it's not a bad idea to take some aspirin to prevent a stroke.
Stroke. So do you have stroke before?
No.
Yeah. Okay. A family history of sudden death or heart disease?
No, doctor.
Yeah. So can I do a physical examination for you?
Yeah, sure.
Sure. I will start with the general appearance and to see if there are any pallor or icterus or cyanosis, lymph node edema, and sure to see your vital signs, blood pressure, and sitting and standing position, and for the pulse, and your temperature and oxygen saturation. I'll do examination for your cardiovascular system. So I have to see if there any carotid berry in your neck or jugular vein pulsation, or I'll do palpitation to see if there are any impulses, abnormal impulses, or if there is or in your sternum. I have to do auscultation to hear any murmurs, different sounds from S1 or S2. Then I can do I can see your cranial nerves or any central nervous system. I can also see um, I don't know. I'll do some office tests like blood pressure, blood count level, or blood sugar level, and for recreational drug. I think that's everything.
Okay. All right, Dr. Zahra, I would just
Yes.
stop here because the time is almost out. So because I would try to do this case with another one as well to see that what they can find out from this case. Because what I feel, Dr. Zahra, you are obviously you are a beginner at the moment. So there will
Yes.
be a lot of things that
Sorry.
you'll need to do about it. That's totally fine.
Yeah.
You did give it a try. That's all that matters. And hopefully by the time when you are in the middle of your preparation, you will know that you're friends when you do a lot of role play. So do a lot of role play and go through these cases that we have discussed, because there is a particular pattern of this recurrent fall case that we have discussed. So that what I would like to hear from someone, that if they can do in that way. And then after that, we will discuss this case a little bit. Okay, Dr. Zahra?
Thank you, doctor. Yeah, sure.
Thank you. Okay, who is confident to do this case? I think there was one at the, so let's see, Dr. Ajira, Dr. Mays. Dr. Azra, did you do a case with me last time? No? Good. So unmute yourself, please.
Hi, Dr. Arshan. How are you today?
Hi, how are you?
I'm good, thank
How are
you.
you? Great. Okay. So you have seen the case already. Do you want to start or do you need 1 minute time?
Yeah, I can start.
Great. Okay, let me just give you the time. So your patient name is David. You can start.
Mhm. Okay, thank you. Hi, David. I'm Dr. Azra, one of the doctor here in the practice. So I understand from the nurse that you are having recurrent fall history for the 2 consecutive nights. Is it right?
Yes, doctor.
Okay, I'm so sorry to hear about it. And would you please excuse me for a second? I would like to ask the examiner about your stability.
It is okay. This is online.
Oh, okay, sorry. Okay, so can you please tell me more about it, like about your recurrent falls? So is it for the first time you had the falls?
Yeah, the doctor, just for the last 2 nights, I've been having this fall. This is quite strange for me because normally I'm really good. I never fall like this before.
Okay, so can you please describe a bit for me? What do you mean by fall? Is it like, have you lost your consciousness or it's just a fall?
It's just a fall. It's just like when I try to get up in the middle of
Mhm.
night to go to the toilet to pass urine, and just at that time when I get up from the bed, I feel dizzy and then I have a fall.
All right. So do you get any warning signs before you fall, like blurring of vision, any weakness of any part of your body?
It's a very like if you ask me, it will be like a very transient one that I know that I'm going to fall. Yeah.
Mhm. Okay. Okay. All right. And how about okay, and no loss of consciousness. Okay. Okay. So is there any possibility that you are taking medications?
Just like I take aspirin and some other multivitamins and some paracetamol and ibuprofen time to time.
Okay. So can you please tell me the reason for what you are taking aspirin?
Just to prevent any stroke or heart attack, one of my doctor told me.
Mm-hmm. And did they tell you why you need to, means like, do you have some risk factors like high blood pressure or any heart disease previously?
Not really. I used to smoke a lot, so that might be the reason.
Mm-hmm. Okay. Can you please tell me more about your smoking, like of how many cigarettes and for how long you have been smoking for?
Since I was a teenage, I smoked and I quit 5 years ago.
Mm-hmm. Okay. So, okay. And you are not smoking anymore.
No,
Do you take alcohol as well?
uh, no, doctor. Just very occasionally.
Okay. Okay. So do you have any shortness of breath, chest pain, or any racing of the heart?
No,
Okay. And no weakness of your, miss any part of your body? No?
no,
Okay. And right. And do you have any vomiting, diarrhea, or anything like that?
no.
Okay. And so is it just your recurrent falls is just at night when you get it from your bed?
It happened in the night mainly, but
Mhm.
nowadays in the morning also when I try to get up, if I do it very suddenly, then I tend to fall.
Mm-hmm. Okay, I'm so sorry about it. Okay, so do you have any history of any like diabetes, I would say? Diabetes?
No,
Okay, okay. Do you have any vision problem like with your
no,
eyes? Okay. Okay, thank you so much for your history. And okay, any family history of any heart disease?
No?
Okay, thank you. Okay, would you mind if okay, I would like to do the physical examination of my patient. Okay, online. Okay, so I would like to know on the general appearance if there is any pylornis, lymphadenopathy, cyanosis, and I would like to know if there is any obvious sign of trauma, and I would like to know vitals and BMI. And I would like to especially focus on the CNS and CVS examination. In the CVS examination, I would like to see if there is any like cardiac, visible cardiac impulse, or on palpation, if there is any thrill, heave, and deviated apex beat, or on auscultation, if there are any murmurs present. And especially in the CNS examination, I would like to do the CNS examination, whole CNS examination along with all the cranial nerves. And I would like to quickly do other musculoskeletal examination as well. And I would like to know if there are urine dipstick and blood sugar level and ECG present. Okay, vitals. So okay, thank you. Hi, David. Most probably, you are having condition known as postural hypotension. It's actually it's not a diagnosis, but it's showing some it's indicating some diagnosis. And in your case, most probably you have a low blood sugar level, which we call hypoglycemia, which was just 4. And maybe you are having this falls because of the low blood sugar level. But the other causes, it could be due to a lot, if the patient is taking a lot of medications, or if there is a problem with the brain or CNS, means brain or heart, or it could be because of the vision problem, or any joint problem. Okay,
Thank you.
are you with me so
Okay.
far? Okay, thank you.
Time up, doctor. Thank you. All right, very good, Dr. Azra. You're doing really good. The way of your doing the case is really nice, and being very straightforward, and also, like I always say that you don't need to have an Australian accent. You just need to be clear whatever you are saying. As long as you are clear, they can easily understand you. When you are clear what you are asking, that all that matters. Okay. So the approach is good, just need some more improvement with the history, and also getting the case. Always remember that just because we did not discuss particular thing in the class doesn't mean it cannot come in the exam. In exam, your mind and head should be very broad. That means anything can appear in the exam and anything can happen. So a patient can present with multiple things to you in the exam. I always encourage everyone that don't focus on just the cases and just the finding that we are discussing in the course, because especially during the random role play sessions or the role play sessions with me, you will always find out we are giving something extra just to prepare you, so that you understand that in exam things might be different, and most of the time they add extra thing, they delete something that's important for that case, and then replace that with a new information, and the case become completely different case. So it can happen in your exam. You will always have to be very, very confident on that part, that will, when I go to the exam, whatever I find from the examination history, I will discuss that. Like in this case, if you if you see the PFE card, you can see that there is a urine dipstick positive for leukocyte. That means this patient might have a urinary tract infection. If you ask the patient that you say that you are getting up in the middle of the night and it's been happening a little bit more than usual, that's actually urgency of urine. When an elderly patient has urgency of urination and very recent one, okay, or yes, like urinary frequency or urgency. So if a patient having urgency frequency and that's a very recent for the patient, we should always look for a UTI, because remember, we know that this is a postural hypotension case. Why? That patient is saying that when I get up from the bed, I feel dizzy and sometimes I fall. That means by the history, we know that it is postural hypotension. Then our next thing to find out is what's the cause of it. You did try to find out the polypharmacy, but that was negative. You did try to find out about the diabetes, that was negative. But what about the infection? Because infection itself can cause postural hypertension. In such case, it's always what you find from the history. Whenever you found from the patient that it's happening at the night time, he's going to the toilet more than usual, go a little bit more deeper that what's the reason of it. Now, even if you miss that initially in your history, when you have got the finding in your screen on the PFE card, then at least you should ask the history that, well, are you having like any discomfort while you are passing urine? Or then you can also find out how many times at night time you need to go to the toilet, what's happening in the morning, how long this is happening for you, did you have any urinary infection before? So few questions, if you ask, you would get everything positive. Okay, so that's one finding. The other one in here is that when you ask about the physical examination, I will come to that point later on, but asking the blood pressure and the blood pressure in sitting and standing position is very important. So when you say that, like what kind of physical examination you are going to do, so we will need to say that what actually we are looking for. I will come to that point after the history. And also patient having BSL-4, which is just on the hypoglycemic range. Less than 4, we call it hypoglycemia. 4 means it's okay, but patient is actually on the lower level of normal blood sugar. If you ask the patient about hypoglycemia, you will find out patient is skip meal in the night time and not eating that much. So you will find out that, so this was the positive finding in this case, getting up abruptly from bed at night, skipping meals at night, which can be the cause of the BSL getting into the low normal range. Patient also had positive UTI symptom, no diabetes, no other issues. Okay, so the history part, I would say that the initial approach was very good. And after you have done that, you start with the pre-syncope, syncope, post-syncope question. That's the important question. So what happened before fall? You ask that, did you feel dizzy? We should also ask that any weakness anywhere, blurring of vision, any kind of speech difficulty, okay? Then what happened during the fall? If the patient did not lose consciousness, we don't need to ask like a lot of syncopal questions. Even if you want, you can ask that by any chance you had any jerky movement of your body. And after fall, were you confused or drowsy? Did you have any weakness anywhere in the body? So those pre-syncopal, syncopal, and post-syncopal questions also come in here. We know that patient did not lose consciousness. Still, we will ask the questions of before fall, during fall, after fall. Head injury will be a good thing, especially after fall. Did you hit your head by any chance? Then you move on to the differential diagnosis. So all the CNS questions, you have already asked most of the question. Ask about any fever, headache, vomiting, neck stiffness to rule out meningitis or encephalitis. Then serious questions, chest pain, difficulty breathing, racing of your heart. Then the others, as we discussed in the class, endocrine question, electrolyte abnormality questions, and don't forget about the home situation, very important. Okay, and obviously SADMA, past medical history, social histories and any enough, like who do you live with at home? Have you got enough support at home? All of this will come into your history. So history should be with that focused one that we have discussed in the recurrent fall cluster. When you come to the physical exam, this is online version. So the question is explain what physical examination you will do to the examiner, and then a PFE card will appear on the screen. Give diagnosis and DD with reason. So which means that in this case, first you will explain to the examiner that what physical exam you, you are going to do. So obvious, excuse me, guys. Sorry. So obviously in this case, we would say that, dear examiner, I'm going to do physical examination on my patient who presented with this, like you can say, who presented with recurrent fall for the last 2 nights. First, I will have a look on my patient. Now, don't use the term I want to know or I would like to know. I always say that how I am going to do the physical exam. So first, I will look on his general appearance for if he looks comfortable or in distress. Then I will check his vitals. First, start with his blood pressure in sitting and standing position to rule out any postural drop. Then I will check his pulse rate and rhythm, and then respiratory rate, temperature, and saturation. Then I will start looking at his neck for any raised JVP or any cardiac bury. Then I would do a focused cardiovascular exam. Especially, I would look for any added murmur or any other abnormal heart sound, any pericardial rub. Then I will do a respiratory examination for bilateral equal air entry. I will also do a complete central nervous system examination, both upper limb, lower limb, including the cranial nerves, for any sign of neurological deficit. And then I will do some office test, especially looking for his blood sugar and urine dipstick, please. Once you say that, then examiner will give you the card on the screen. You just read it very quickly and find out what's the finding that they have given you. And then give your diagnosis that this is postural hypertension. Explain what is postural hypertension, how we did in the class, and then say what's the likely reason. Likely reason in his case is the recent infection, likely that he has got an infection in his urine, which is causing this kind of fall that he has got. And then give that what could be the other cause of this postural hypertension. So vomiting, diarrhea, if he is having like multiple drugs that can also cause it, okay? If patient has got diabetes, it can cause it. So just say that this could be the cause. Also, don't forget to say that I have also found your blood sugar level is on the low normal range. It could be that you are going into the low blood sugar or hypoglycemic event. So I would encourage you to have some meal at your night time, and that will obviously help with your symptoms. Okay, so everything that you get from the patient should be included in your explanation, and then give all other DD of recurrent fall. Everything is clear for everyone? Did you guys get how actually online exam can happen? How long will be the PFE card on the screen? There is nothing like that. It depends. So I encourage everyone to know the task, because it's always important that you don't wait for the examiner or the invigilator to change the screen for you. Whenever you finish your physical examination card reading, go to the next task. You should always know that what's your task in the exam. So normally when you finish your PFE card reading, then usually they change the screen. Or when you finish it, if you can always ask the invigilator, can I please have a look on my first screen? They can ask management, yes. How long on online exam should we take for explaining the PA just to finish on time? I would say like this is not a full physical exam in here you are doing. 1 minute is usually the ideal. Highest 1 minute 30 seconds, not more than that. Yeah, so postural hypertension due to UTI, the treatment, first of all, you have to treat the UTI. And then after UTI is treated, then you will follow up the patient just to see that even after UTI treatment, still patient has got the fall or not. You don't need to send the patient to the recurrent fall clinic for this, because apart from UTI, there is nothing else that you have found. Okay, so first you treat the UTI with antibiotic, then ask the patient to come back to you. You can do a repeat urinary MCS just to see that if the UTI is resolved. And after that, you just keep an eye on the patient to see that if there is any other recurrent fall happening or not. Okay, so that's it for it. Let's move on to the next role play. Let's not take just 1 hour for one role play. In that way, you will not get any help. So who wants to do the next one? I will just follow the initial one that you have said, that who wanted to do the role play first. Follow-up should be after finishing the antibiotics. So for men, usually we go for 7 to 10 days of UTI treatment. So after 7 days, you can have a follow-up with the patient. Okay, the next was Dr. Mays Al-Wash. So do you still want to do it?
Yes, doctor.
Good. Okay, so let me give you a case. Okay, so this is your case. Your 1 minute time just started.
All right.
Okay, doctor. So your patient name is Sarah. You can start.
Good evening, Sarah. It's Dr. Mace Abrash, one of the HM1 the emergency department today, and I will be taking care of you. So, Sarah, I understand from the notes here that you have the palpitation. So, can you tell me more about this?
Yes, doctor. So for the last 2 hours, I've been feeling that my heart is racing, and I can't.
Yeah.
I am also having difficulty to breathe, and I'm feeling quite dizzy.
All right, I'm sorry to hear about that. I have some more questions, if you don't mind. So, how did it happen? Was it sudden or gradual?
It just started suddenly because I was just like working at my kitchen, And then suddenly I
Yeah.
just felt it started this thumping action.
Yes. So we're standing in a hot kitchen.
No, doctor, it was not a hot kitchen.
All right. And have you had any similar episode previously?
Yeah, I also had this for the last, I think, other 2 episodes. And, you know, at one time I was just running in the outside. At one point, I was just sitting and watching TV, and it happened.
Okay. And when was that episode?
I think one happened 5 months ago and another 3 months ago.
All right. And what did you do at that time? Have you sought any medical advice regarding this?
No, it just stopped by its own.
All right. And can you tell me, please, do you have any chest pain, any with this racing of the heart?
No, doctor, no chest pain.
So, and you mentioned that you had some difficulty breathing, right?
Yeah, it's a little bit, not too much.
So, did this follow the racing of the heart, or it was preceding it?
Sorry, doctor.
So it occurred concomitantly together with the racing of the heart, or it preceded it?
It just started with the racing of the heart.
With the racing of the heart. And for how long did this racing of the heart lasted?
The racing of the heart lasted for 2 hours.
Yeah. So, is there any chance you have a history of trauma lately?
No,
Do you have any? Do you feel tired like most of the day?
no,
Any loss of appetite?
no,
What about your bowel habits and water work? Have you noticed any change?
no,
Do you feel sweaty, especially in the palms of your hands?
no,
Have you noticed any change in your weight?
no,
And have you noticed any mass or like a lump in the front of your neck?
no,
Any other preference?
no.
And what about your cycle? I'm going to ask you some private questions. So, have you noticed any change in your menstrual cycle?
No, I'm still having regular menstruation.
Yeah. And when was your last menstrual period?
3 weeks ago.
All right. So, do you have a stable sexual partner? Are you sexually active? I'm sorry, these
Yeah.
are private questions, and let me assure that everything will be confidential, just between you and me, right? Any problems with your
Yeah,
menstrual
I'm sexually
cycle? Any
active.
irregularities? Yeah, any irregularities in your menstrual cycle?
No,
How long does it last?
5 to 7 days.
7 days. And how long does it occurs regularly every time each month?
Sorry.
Have you noticed that it's been changing? It's the duration between each cycle?
No, doctor. My period is fine, doctor.
Yeah. Any use of contraceptive?
No,
All right. Do you have any vomiting or diarrhea lately?
no,
Any headache? Repeated vomiting? I'm sorry, about vomiting. Any headache?
no.
And what do you do for a living, Sarah?
I just work as a retail.
I'm sorry.
I work in a retail.
Okay. All right. So, have you noticed that you have any stress at work or at home?
No, doctor.
So, do you consider yourself as an overthinker or a perfectionist?
No.
Does this episode ever related to a certain situation, like when you are out?
No.
And do you have any previous medical condition, for example, high blood pressure or diabetes?
No, doctor.
Any heart problem?
No.
Do you have any family history of similar condition or a premature death?
No, doctor.
All right, and you smoke?
Just occasionally.
Occasionally, and how much?
I don't count, doctor, just very occasional.
All right, what about alcohol? Do you drink alcohol?
Occasionally.
Occasionally. All right, do you do any recreational drugs?
No.
Any particular medications for any reason?
No.
All right. Do you have any previous surgeries that I should be aware of?
No.
All right. Thank you, Sarah, for sharing these informations with me. I'd like to do some investigations with investigation, sorry, to make sure of the underlying cause. The investigation that I would like to do, first of all, I would like to do an ECG.
Thank you, doctor. Time up.
Sorry.
It's okay. That's really fine. Don't worry. So
Can I discuss
I'm
further?
just going to. No, that's all good. So what I actually want to make sure that the idea of this timing is the most important part, because if I allow any of you to discuss this after the time, you will never learn the importance of the time, because if the time goes out like this in the exam, nothing going to help. Okay, so Maze and Mariam, I'm just going to unmute you guys because there's a lot of noise coming from your ends. So we'll just keep you muted, and also please don't unmute anyone, or you'll just keep you muted for now. So the important part in here, Dr. Mays and others, that we will not allow any of you to go past the time in the course. I know that you would feel better to discuss that. Like if you could discuss the other two, that you would feel better in your head. But if I allow you, you will never learn the importance of the time. Okay, the time is very, very important part of this preparation. Without understanding how much you can talk, and if I don't stop you right away, your mind will never be able to perceive that time. So because you can't actually look at the watch, and it's all about how much perception you have about the time in your head. That will matter in the exam. So always, like if you are doing role play with your partners, don't allow anyone to go further than 7 minutes 30 seconds. Time is up, it means up. Okay, so that's the one of the best way to learn about the time. Okay, so always practice in that way. When time up, you know that this is what I have done this today, and next time when I'm going to do the role play, I will try my best to make sure the history is not going for 8 minutes, right? So obviously, like it's not needed to ask that much of a question in the history. Like, do we need to go through the 5P questions of gynae for menopause, just one single differential diagnosis? No, because I found, Maze, you have been asking about lots of period related questions, as if you wanted this case to be a perimenopausal case, which is not needed. Just single question. When was your last menstrual period? Do you have like a regular or irregular period? If I say that it's a regular period, my last menstrual period was 2 to 3 weeks ago, that's fine. It's not menopause, so we don't need to worry about it at all. So we will go to the next question. So that's the reason that always keep it 1 or 2 questions for each of the DD, because you don't have that much time in the exam. As you can already understand that you can ask 6 to 8 minute history, even you will feel that there is a lot of things to ask. But if you just focus on history, the other task will be like this. An examiner will not be able to pass you. Okay, so history should be focused. You already know that they have given you a ECG, might be a palpitation case. So this is a palpitation cluster. You already know patient is vitally stable, so that's good. So you start with your, first you greet, introduce yourself, reassure the patient. Those are very important things. And I always say, you don't need to be having an Australian accent. You just need to be very clear about what you are asking. Time to time, if role player in the exam don't understand what you are saying, then they will keep on asking you, pardon me, can you repeat after it? If you become a little bit faster, I have come across candidates who talk very fast, and that's a part of you, how you talk English. So it's not anything like, this is not something that you should take it personally. This is something what I have found from a lot of candidates, like who are passing the exam, who are not. The important thing is to be slow, like asking questions very clearly rather than going fast. You can finish these 3 tasks on time, even if you are slow, but there is a pattern of asking the questions. Okay, and in that way you can always do it. So if you ask the patient that, well, do you have any chest pain, difficulty breathing? Do you have any weakness anywhere in the body? Any change in your weather preference? Any change in your body weight? So every question, you are actually running like you are doing it fast, but everything that you are asking, they can understand it. That understanding is important. Otherwise, the role player keep on disturbing you throughout the exam, and you will not be able to finish it in time. Same if some of you are doing it very fast, like even no one can even understand what you are saying, that's also not a good idea. So what role player usually says in that time, that doctor, if you keep on being this much fast, I will not answer any of your questions. So that happens. I have heard a lot of this feedback from the candidates where role players said, I'm not going to talk to you because I can't understand anything. So this is also important, because if the other person doesn't understand what you're saying, if you're being very fast, that will affect your whole exam. Dr. Mays, you are not fast, so I'm just giving it as a general idea. So, but I felt a little bit like maybe if you are more fast in the history and also a little bit more clear, that will become much better for your exam. And obviously we can help you with that, and I'm sure you will be much better with the preparation that you are going to have with us. The next part is the history. In the history, you have asked most of the important questions. So CVS, CNS, endocrine, like a few chromocytoma questions can be asked, like do you get episodic headache, sweating, pallor, okay? Those questions we can ask. Hypoglycemia questions, anemia question, menopause you asked. Tea, coffee is important, recreational drugs you asked, and smoking, drinking, family history of sudden cardiac death. So most of the history you asked very good. The investigation was the ECG. Now, Dr. Mays, I'll give you 1 minute to read this ECG and tell me, and just explain the ECG to me.
Yes, doctor. Shall I start?
Yeah, start.
Yeah. So Sarah, looking at this ECG, which means that this represents the electrical activity of your heart and how does your heart work, and it reveals that there is an abnormal in the rhythm, or abnormal in the way that these electrical activities are transmitted throughout your heart. So
Dr.
let me
Mays,
explain to you
sorry
more.
to stop you.
Sorry.
Sorry to stop you. Just
Yes.
explain the ECG to the examiner.
to the examiner. So, dear examiner, here I have an ECG recording of my patient Sarah, middle-aged female who presented with palpitation 2 hours for 2 hours duration associated with the shortness of breath. So here, looking at the lead, looking at lead 2, I can see that there is no P wave, and it seems irregular for me. So, so mostly for an irregular rhythm, and it's not sinus, with no wave, that's not sinus. So the most likely diagnosis I expect that is an atrial fibrillation. And this goes with with history and clinical presentation of the patients. So management, further management.
It's all good,
depends on the
Dr. Mays.
stability of the
You don't need
patients.
to explain it. It's okay.
Sorry?
Thank you. Now,
Yeah, okay.
that's all right. Thank you, Dr. Mays. I still feel like it's a little bit faster. I think a little bit slow will be much more better. Okay, Dr. Mays. But don't worry, it is very common to, this is actually why you are with this course and why we are hearing everything from everyone. And this is the learning phase. In the learning phase, every one of you will do something like this. And what I would suggest everyone, when you are writing any comment, just be very nice to the person, because it's also important that you don't demotivate anyone. You motivate others, because if I ask any of you to do the role play, I might be able to find out something like this with you as well. So when you comment, because these are our fellow colleagues, right? So we will be very respectful with each other, and we will just encourage others. So you can always say something like, well, it's a good idea to speak a little bit slow, but you can't say that like, be slow, you are speaking too fast, not like that. So just say in a very respectful way. And in that way, you will also gain a good respectful motivation and encouragement from the other people. So that's the first thing I also encourage you to do that, because when you do the study, like when you do this role play with your study partner, this is what you have to do. You have to encourage your body that, well, this is what I feel you're doing wrong. And if you can just change it, then I feel like you will do much better. See that this is one of the way. And the other way that you can't, other way is that if you demotivate in a way that she will never do role play with you, that's never going to help. Okay, so it's important. So Dr. Mays, I will say that this is how I would say in this case. So dear examiner, I would like to explain the ECG of my patient who presented with palpitation for the last 2 hours. The ECG shows the heart rate is increased, rhythm is irregular, absence of P wave, which is replaced by fibrillatory waves. Okay, and then you can say that the QRS is normal. There is no ST changes. T wave is normal in size and shape, and the QT interval is normal as well. Just like that. Okay, so that will be the best approach. I would say. I know that the time is always in your head. When you are a beginner, you will always feel like, well, I have to be quick to finish the task. That's actually another problem that happened with the first-time candidate. Most of the time, first-time candidate feel that they need to finish the task in time. They don't care about the patient. They don't care about the other aspect of the exam. This is a simulatory exam, but you can't think in your head that this is just a simulation. In front of you, it's a real patient. You will have to think, and you will have to treat in that way. When you can actually do that, then the difference happens between you and the other candidates who fail the exam. Thank you, guys. So that's actually, I always encourage. So you always motivate others, because Dr. Mays has actually asked everything in the history. And as a beginner, that's really good. She did really good with the history. That's also important. So I would always say that encourage everyone. And you will feel that when you do role play with your partners, they become very, very good influencer for you. You learn from them a lot. And if you don't make that environment, there will be time that you are doing role play, but you are not getting anything out of it. That's not the idea. When we describe the ECG to the examiner, do we need to say diagnosis at the end? No need. If you think that you won, that's fine, but diagnosis is not must. You can say it, Dr. Maria, you can say that, well, I feel like the ECG looks like a atrial fibrillation. You can say the diagnosis. It doesn't hurt. Okay, good. Who wants to do the next one? Yes, Dr. Nijatul, volume is also very important. If you speak very slow, they will not be able to understand you. We will talk about the online perspective in our orientation session a lot, like what actually you are supposed to do in online exam. So we'll give a little bit go about that. Okay, so Dr. Pramodia, you can do it.
Yes, I'm ready.
Good. Now I'm going to do a case which we haven't discussed in the class. Okay. Now just do how you feel, and then we will discuss it. So don't worry if you're doing it right or wrong.
Okay, sir. Is the question dispute? Right.
So this is the question. This is actually the case that we haven't discussed in the class yet. So this is like, first you do it, and then we will discuss what it should be done. Okay. Your time just started. Okay, so this will be a face-to-face case. Okay, doctor. So
Okay, sir.
your patient name is David. You can start.
Hi, David. I'm Dr. Pramodia. I'm the doctor of the clinic. From the note, I understood that your brother underwent a coronary bypass 2 weeks ago. I'm so sorry about that. May I know why you're here today? We are going to take
Doctor,
good care of you. Don't worry.
Thank you. I'm actually very concerned after what happened to my brother. I just don't want to end up like him. So I'm here to just to know that if I'm also having the same risk and what I can do to prevent it.
For that, we'll have to get a little bit more information from you, and we'll do a physical examination, and let's see how it goes, right? Okay. Can you please tell me whether what are your main concerns? What getting the disease, or were you scared of the surgery? What made you so worried about it?
Yeah. I don't know, love doctor. I just don't want to end up like it. That's it.
And there must have been many reasons that your brother had some kind of that kind of a disease. All right. It's not a assurance that you're also going to get it if your brother had it, but there's some risk. Okay. For that, to understand the risk, we'll have to ask a few questions. Do you have I understood from the notes that you are not having any other diseases such as diabetes, hypertension, or cholesterol, all right? Is that true?
Sorry, doctor. I usually don't have any such condition, doctor. That's right.
Okay, okay. But I understood from the notes that you are a little bit overweight. Are you taking, how is your lifestyle? Are you taking a good diet, or are you more into fatty food? Are you taking
I
alcohol or
live alone,
smoking?
doctor. So most of the
Mhm.
time I just need to go out and take some food from outside. So
Mhm.
the food habit is not that good. And because I also work about 50 hours a day, and that's mostly just sitting in front of the computer. So I don't usually get that much time to do any exercise.
Okay. Do you smoke or drink?
I do smoke, yes, but occasional drinking.
For how long have you been smoking, and how many cigarettes that you take per a day?
Usually 15 cigarettes per day.
For how many years have you been taking like that?
30.
How many years have you been taking smoking cigarettes like that?
30 years.
30 years. All right. And is there a family history of any heart diseases or heart conditions other than your brothers? Someone who died of young age, or your parents had it?
No.
Okay. And you said that you are working most of the times of the day. Is it very stressful?
It is quite stressful, doctor.
Mhm. Do you have any hobbies or anything that keeps you occupied other than work?
No.
Mhm. Okay. And do you feel sad most of the time of the day?
No, doctor. I usually feel very occupied of this job. Yeah, but no sadness or anything like that.
No sadness or anything like that. Are you on any medication for anything?
No.
Okay. Have you done any of the investigations of your blood investigations recently?
No.
All right. I would like to speak to my examiner and know your physical examination. Can you please excuse me for a while?
Sure.
Okay. Dear examiner, I want to know the general appearance of my patient. Is he looking okay, or is he
He looks comfortable.
is comfortable? Okay. Is the patient having any pallor or cyanosis?
No.
Any lymphadenopathy?
No.
I want to know the patient's blood pressure, standing and sitting, and also the pulse rate, rhythm, volume.
Blood pressure is 145 by 90, and the pulse rate is 98. Regular rhythm.
I want to know the patient's BMI, please.
BMI 34.
I will do the patient's cardiovascular examination. Starting from palpation, is there any is the cardiac apex beat deviated? Is there any parasternal
No,
hemorrhage?
the CVS examination is normal.
No. Respiratory examination is focused on AMC and everything. And any
No,
other signs?
the respiratory exam is normal.
I would like to do the patient's abdominal examination, including any hepatomegaly or splenomegaly.
Normal.
Any other important findings in the CNS examination or the brain?
Negative.
Okay. Thank you, examiner. I would like to documentation. Hi, David. Hello, I'm Nita.
Yep.
Hello, I'm back. Thank you for waiting. First of all, I would like you to know that there are conditions that can lead to heart attacks that can be modified and that cannot be modified. Okay. The good thing is the modified things are the ones that we can alter and help you lower the risk of heart attacks. There are few things that we identified from your case, from the examination and the history. But I want you to know that with proper support and with proper help, you can overcome, you can lower this heart attack risk to a very low level. All right. Are you with
Yep.
me? First of all, we'll have to modify some of your lifestyle patterns. I understand that with your busy schedule, it's difficult for you to prepare meals, but there are healthy options for your food pattern, right? We can always go for salads and other healthy and a balanced diet would help you.
Thank you, doctor.
Okay, thank you, sir.
Thank you. Dr. Pramodia, you did good. It was a good case that we didn't discuss it in the class, but still you did really good. Okay, so the history physical examination from examiner, let's just discuss this case and then you will also know that what we have missed and what can be done a little bit more better. Okay, so this case is all about CVD risk assessment. So one of the very most important thing that Dr. Pramodia didn't ask is that CVS risk assessment chart. So that obviously is an important part of this, because with that CVS risk assessment chart, you can actually tell the patient that if you are high risk or moderate risk or low risk. You must have remembered that from the MCQ preparation, there was a CVS risk assessment chart, which we call 5-yearly CVS or CVD risk assessment. That chart is the one that we want you to ask in the exam. In some cases, they don't give it to you. In some cases, they give it to you. So we just need to know about it a little bit more. So first of all, in this case, the CVS risk assessment, first the history is we follow this mnemonic of ABCDEFS. So what is ABCDEFS? A for alcohol intake, B for blood pressure and body weight, C for cholesterol, D for diet and diabetes, E for exercise, F for family history of heart disease, S for smoking, and another S for stress, and then just ask about any other past medical or surgical history. So that's the main part of your history in this case. First of all, in here, we would start in this way. Hi, David, this is Dr. Pramodia. I'm one of the GP in this clinic. It's very nice to meet you. I'm very sorry to hear about your brother. How is he doing now? Thank you for asking, doctor. He's doing okay. All right, that's really good to know, David. Now, would you please tell me a little bit more that what exactly you wanted to discuss today? So then patient will give you the information that why he is here. Then you appreciate the patient. Say that, David, that's very good. I really appreciate that you are here to discuss about it. A lot of patients would not do that. And certainly I can help you with that. So before I can give you some more information about this risk and how to prevent it, I just need to find out some information from you. Is that okay with you? Yes, doctor. So can you please tell me a little bit more about your lifestyle? So you can start with the lifestyle, that how is your diet? Do you do any exercise? Okay. And How about smoking and alcohol? Who do you live with at home? Is there any stress at your home or work? And do you have any known medical condition like diabetes, high cholesterol, or high blood pressure? Okay, and then ask about past medical surgical history, ask about family history. So it's not a very large history. Also, don't forget to ask about any symptoms of cardiac condition right now. So are you having any symptoms related to heart right now, like any chest pain, difficulty breathing? Do you get puffy or short of breath when you do any exertion? So just ask few questions and that should do it. After you have done the history, then you go for physical exam. Physical exam, first of all, general appearance. Does the patient looks comfortable or distressed? And don't forget to ask about any sign of hypercholesterolemia like xanthelasma, xanthoma, or corneal arcus. Then pickled as we do, vitals, blood pressure is very important in here. In this case, I gave a blood pressure of 145/90. That's a risk, right? Because this patient is hypertensive. You can't say patient is having hypertension without doing another blood pressure checkup. Maybe in another week time, you can do another blood pressure. So we say that at least 2 different occasions, you will have to get high blood pressure, more than 140/80. Then you can say that patient having hypertension. Okay, even we can say that more than 140/90, that's the high normal range, 140/90. So anyone having more than 140/90 in 2 separate occasions, that's hypertension. So that's one of the important things that you need to address in your management. BMI is high in this patient. Then just finish with severe respiratory abdomen and ask the office test for urine dipstick, BSL, and the ECG. ECG is a very important thing. It can help you to find out any heart condition already the patient having. At the end, you should ask from the examiner that, examiner, I would like to know if the 5-yearly cardiovascular risk assessment chart available. If examiner give it to you, then you can always find this out from the history and everything. Most of the time in this case, they don't give it to you, but still it should be asked. So what you're going to say that from history and physical exam, I have found some risk factors, like you have high blood pressure, your body weight is higher than normal. Now, it depends what you have found. If you don't get diabetes, then don't say it. Your diet contains fatty food rather than healthy balanced diet. And also you have been smoking for quite a long time. Okay. If you have got some other finding like this patient having stress, you can talk about it. This patient having sedentary lifestyle, you can talk about it. So whatever is your finding, you just need to add here. All this can put you on some risk for having heart-related complication in the future. But please don't get scared because we can prevent this by adopting a healthy lifestyle. First of all, I would advise you to cut down the alcohol to safe level. Try to quit smoking. Try to maintain an ideal body weight. And for that, you need to take a healthy balanced diet and doing some exercise, ideally 30 minutes of brisk walking most of the days of the week. And I know that you are under a lot of stress at your work, and it's also very important for you. But it's important to understand that this stressful life can put a risk on your heart, especially now you are having high blood pressure that can be directly related to your stressful life. So I would advise you time to time, take some off from your work, reduce the working hours a little bit because you are working 50 hours in a week, which is more than normal. And just go out, have some fun, and even sometimes take a vacation for a week. That's always important, and it will make sure that your stress is well managed, and a lot of other problems that you are having, it will be gone by that time. But to give you the appropriate risk, I need to do some investigations first. So we will order some basic investigations like full blood count, your kidney function. We will do an ECG on your heart, blood sugar level, and a lipid profile. Once I get all of this, then I will put your age, your smoking history, your cholesterol, and your blood pressure on a chart, which we call 5-yearly risk assessment chart. And by that, we will be able to tell you how much is the risk that you have got. Okay. And then lastly say, I would like to give you some reading materials about everything that and I will review you once these blood tests are back. Do you have any questions? Okay. So that's how we would say. Now let's say sometimes they can give you this question in which they give you every information that you need to estimate the cardiovascular risk of the patient. So this is a 57-year-old male, came for follow-up. Brother had a bypass surgery. You have found patient's systolic blood pressure is 160 and cholesterol HDL ratio is 8/1. So this is the risk assessment chart. In the risk assessment chart, there are a few things that you need to keep an eye. So this is women, this is men. And then you have got a smoker and non-smoker. So we have found this patient is a 57-year-old. Let's say this patient is a smoker. Yeah, so he's a smoker. So men 57. So this is the 57 group, smoker, right? So we are mainly looking on this part. Then you need systolic blood pressure, that's on your y-axis, and then cholesterol HDL ratio on the x-axis. So the first thing that you should remember that in here, you see that systolic blood pressure is 120, 140, 160, 179. Remember one thing, that this box, what is the highest systolic blood pressure that you can put in this box? Not 120. So up to 130, you can put it here. Same on this box, up to 150, you can put it here. All right. Now, if you come to the cholesterol HDL ratio, you can see 4, 5, 6, 7, 8. So in this box, how much cholesterol you can put? 4.5, not 4. Same with this box, how much? 5.5. Okay. So if you understand this part, this chart is very easy. Is this clear for everyone? Usually CVS risk assessment is done above patient 45. So now you see that our patient has got systolic blood pressure of 160. So we find out that what is the 160 range. So we'll be looking into this box, right? So 160 means that we know that up this box, this red one, got up to 170. So 160 will fall in this box, right? Or anywhere. So along this line. Then we have got 8. So 8 is our cholesterol ratio. So 8 if we go up. So yes, so this is the red one that the patient will fall on. If the patient's cholesterol was 5, then we would come in this box, right? So that's how we do the graph. So red box, you can see that this patient has got a high risk, more than 30% risk of having a heart attack in the next 5 years. So you'll just need to explain the risk to the patient in that way. There is no why in this case. This is how the risk assessment chart is designed. Okay, so this is from Australian guideline. There is the specific reason why we just put 4.5 here. So if I give you the idea again, this y-axis 120, 140, 160, that's your systolic blood pressure that you will keep here. So you see that 120, so this box up to 130 you can put it here. Same with this box, up to 150 you can put it here. Okay. For the cholesterol part, you have got 4, 5, 6, 7, 8, but this box will get up to 4.5. This box 5.5, 6.5, 7.5, 8.5. Okay, 4R we will discuss a little bit more in our pediatric vomiting cluster. All right, so don't bother with that today. And as I can see, many of you has already written that's reading material, red flag review and referral, but that will come in detail in pediatric class. Let's move on to the role play. So who wants to do the next one? Dr. Farhana, you can unmute.
Hello.
Hi, Dr. Farhana,
Hi,
how are
doctor.
you?
Yes, I'm good. How are you, doctor?
I'm good, thank you. Okay, so let me give you a case. All right, so this is your case. If you need to see the ECG, just let me know.
Okay.
This will be an online format. So this is your patient, Dr. Farhana. The patient's name is Sam. You can start.
Okay. Hi, Sam. I'm Dr. Farhana, one of the GP here. Very nice to meet you.
Nice to meet you.
I understand from the note that you are having chest pain, which is started from 30 minutes ago. Do you have still pain right now?
Yes, doctor.
Okay. I would like to give you a painkiller that might give you some comfort so that we can start. And do you have any medication allergy?
No.
Okay. Before asking you any questions, I would like to know from my examiner that is about your vital stability. Is that okay with you?
Yes.
Okay. Dear examiner, I would like to know the physical hemodynamic stability of my patient. Is that okay? Okay, Sam, I understand that you are vitally stable. Now, I would like to ask you some questions, but if any question or concern regarding anything, please ask me anytime. Don't hesitate. How are you feeling right now, John? Sam?
I'm still having the pain.
Okay, and can you please score the pain for me like 1 to 10? 1 is the mildest and 10 is the very severe pain.
10 by 10.
Okay, I'm really very sorry to hear that. What are you doing? Can you please tell me more about your pain? Like what exactly
Yeah,
happened?
doctor. So I was just jogging in the at outside, and then suddenly the pain started.
Okay. Okay. Is it for the first time?
Yes.
Okay. And uh, uh, anything that makes it better or worse?
No, doctor.
Okay. It is continuous or on and off pain?
Continuous.
Okay. And do you have any associated with the chest pain? Do you have any like shortness of breath, racing of heart, and any excessive sweating, nausea, vomiting?
Yes, I feel nauseous and also having difficulty to breathe.
Okay. And does the pain goes to the anywhere else?
Yeah, it goes to my left arm.
Okay. Okay, John. Can you please tell me that is it worsening with leaning forward, worsening with the lying down, or better with the leaning forward?
No,
Okay. And do you have any fever, rash, neck stiffness,
no,
any cough, and any history of trauma?
no,
Okay. And do you have any relation with the food intake associated with this pain?
no,
Okay. And do you are you generally an anxious person, Sam?
no, doctor.
Okay. And I would like to ask you some personal questions. Can you please tell me whom do you live with?
With my partner.
Okay. And is there do you work, Sam?
Yeah,
Is there any stressful condition going on in your home or in the workplace?
no,
Okay. And do you have any rashes over the chest?
no.
Okay. I forgot to ask one question. Can you please exactly locate the pain for me in your chest?
On the left side.
Okay. Uh, okay, Sam. I would like to can you please describe the pain for me? Like it is squeezing or crushing or it is constricting? How it feel?
It feels like something is sitting on my chest.
Okay. And how about the past medical history? Do you have any diabetes, hypertension, or any history of heart disease?
No, doctor.
Okay. And do you take sorry to ask you questions like do you smoke, drink alcohol, or any recreational drug?
Yeah, I smoke most of the time 15 cigarettes a day and occasional drinking.
For how long, Sam?
30 years.
Okay. I would like to make another appointment for the smoking counseling. Is that okay with you?
Yeah.
Okay. And I would like to know do you have any family history of heart disease?
Yeah, my brother and also my father had a heart attack.
Okay. Okay. Thank you, John, for your cooperation. Now I would like to explain the ECG to my examiner. Thank you. Dear examiner, I would like to know the ECG finding. Okay. Uh, Dear examiner, this is the 12-lead ECG finding of my patient Sam. The ECG shows that P wave is normal. Heart rate is about heart rate is normal about 60 beats per minute, and and also the rhythm is regular, and um, rhythm is regular, and P wave is normal, and there is ST elevation present in the V1 to V6, and there is T inversion also present in the V2, V3, and V2, V3, V4, and V5. And QRS complex is normal, and other examinations are also normal. So I would like to say that it is the ECG of the anterior MI. Um, Dear Sam, I would like from the history and physical examination, from the history and ECG finding of you, I am suspecting that you have a condition which is called the acute anterior MI. Do you know what it is?
No, doctor, what's that?
Okay, actually, this is the I'm explaining it with you. And this is your heart, and there is the fourth chamber, and if any, and there are the coronary vessels. This is the artery blood supply of your heart, and if there is any narrowing occurring in the
Time up. Time up, doctor. But I would say just explain what would be the management, because I would like to know about it.
okay. This is the fourth chamber of your heart, and this is the blood vessel which is supplying the heart. And if there is any narrowing of the blood vessel, and then your there is blood supply, there is a hamper of the blood supply, and that is why your heart is not getting enough oxygen, and which causes this type of pain that is you are having right now. And I would like to send you to the resuscitation cubicle emergency, and I would like to admit to the hospital, and I will ask the nurse to make an to wardbore IV channel, and also put oxygen, oxygen 6 to 8 liter per minute, and then I'll give you some painkiller like morphine, aspirin, and nitrate, sublingual glycerin trinitrate. And then I would like to I would like to liaise you to the refer you to the tertiary care hospital, so that yes. I would like to give you some streptokinase like clotting agent, and that so to dissolve the clot which is happening in your blood vessel, and for that reason I would give you streptokinase, and after that I would like to refer you to the tertiary care hospital for the better management, and I will liaise with the hospital as you are having this type of condition and you are having the chest pain. And after reaching the hospital, they will manage you, and you will be seen by the cardiologist, and he will do some investigation like full blood examination,
Thank you, doctor. Mr.
echocardiography.
Goel.
Okay.
Thank you so much. That was good. Very good, doctor. So I'm happy how you did it, but the timing is not right. The main issue is the history. Look at here, brief history. You don't need to ask everything in this case. And you took, you just had 30 seconds for the management. So that means you took a lot of time for this brief history. Brief history means just a little bit. Like, as I say that if the ECG is given, then you can always ask the invigilator to have a look on the ECG first, because if it is a part of your stem, likely chance that ECG is there. And if you just ask the invigilator, they will show the ECG to you. Many times they just keep the ECG on the same screen so that you can have a look. So if something like that is written, like ECG is given, then you just ask the invigilator, can I have a look on the ECG during that 2 minute outside? Because in that case, you can already know that this case is a heart attack or MI case. Then you don't ask a lot of differential diagnosis anymore. So the history will be just like you, but remember this is an online case. I always start in this way. So, hi John, this is Dr. Farhana. I'm one of the GP in this clinic. I'm sorry to know about your chest pain, but now that you are here, I'm going to take care of you. So can you score your pain in a scale of 1 to 10? So patient says 10 by 10, then say, I'm really sorry to know that. I'm going to arrange some strong painkiller for you. Do you have any allergy to this? No, doctor. Well, I'm going to give it to you. So before I ask any more questions, John, I just need to make sure that you are vitally stable. And also I need to take you to my treatment room so that I can ask my nurse to hook a ECG monitor with you, and we can do an urgent ECG to find out any changes in your heart. In the meantime, we will also check your oxygen, your blood pressure, pulse, everything, just to make sure you are stable. Is that okay with you? Yes, doctor. So at least you will have to take this patient to the treatment room and do these steps initially if you can. It will be a much better approach. especially if you already know from the ECG that it's a heart attack, you can always take the patient to the treatment room straight away, and you can hook the patient to the ECG monitor, take some blood for necessary investigations, check the oxygen. If the saturation less than 94, start the patient with oxygen. You don't give the myocardial infarction diagnosis straight away before taking the history. You just do this initial management. Even you don't need to start the patient with aspirin or any of the monotherapy like aspirin or nitroglycerin, because in that case, you will need to say to the patient that what's the diagnosis. So I would rather just say that I'm going to take you to my treatment room and then ask my nurse to hook you to a ECG monitor and to keep an eye on you. We'll take some blood for necessary investigations. We will check your oxygen. If it's low, then we will start you with some oxygen. Now, would you please tell me a little bit more about the chest pain? Then you ask all the chest pain questions. So all the Socrates questions, associated questions. Then remember, you don't need to ask even any differential diagnosis in this case. Lastly, you can just ask some of the risk factor of AMI, like smoking, alcohol, family history, lifestyle, and that's it. After that, you go to the ECG explanation. Your ECG explanation was good in here. So it was actually a heart rate of 60, rhythm regular, then talk about P wave and everything else. In here, there is ST elevation from V1 to V6. Then also, you did not talk about lead 1 and AVL. It's also ST elevation. Nothing on the lead 2, 3 AVF. There is T inversion in lead 1, V1, V2, V3, V4, V5, V6. Lead 1 and lead AVL as well. 1, we can't see that much, but AVL also. So generalized T wave inversion as well. There is also one other thing in here that you can see. See this M pattern, this M-like thing. This is a bundle branch block as well in this case. Okay, so you can even say that there is also some M pattern on which leads you can see those M pattern. Like usually I can see there is a generalized M pattern most of these areas. So you can say there is a M pattern in obvious in lead 2, 3 AVF. And it's likely to be there is some bundle branch block in this case as well. So that's the ECG. And after that, the explanation is very important. So you explain what is heart attack, say sorry, say that it is emergency situation, but in here you're in a GP clinic. So say the first monotherapy. So talk about morphine, aspirin, oxygen, nitroglycerin, as we discussed in the class. And after that, say that now the definitive management is to give you something to dissolve this clot. But right now we are in a rural area and the nearest hospital is 4 hours away. So we don't have that much time to transfer you to the hospital and treat you there. So I have to do something straight away so that we can save your heart muscle from dying. So what I'm going to do is to call the nearest tertiary hospital and also involve the cardiologist. And I will talk about you to see what is the best approach in your case. Most of the time in this situation, we go for a medication known as a streptokinase, which is a clot dissolving agent. And because it's a 4 hours away and we can't wait for it, most likely the cardiologist will advise us to go for that. In that case, we will make sure you don't have any contraindications to that. And if everything is fine, then we will go for it. And then also we will ask for an air ambulance to transfer you to the tertiary hospital as early as possible. In the hospital, the cardiologist will review you, do some more investigations, and if needed, they will do further management. Okay, now as a junior doctor, you will never say that I'm going to start you with a streptokinase without cardiologist opinion. Straight fail. So very tricky area. You will always need to say that I'm a junior doctor. I will need to talk to a cardiologist for further management in this situation. Okay, and most of the time, this is a rural situation. Usually it will never happen in a GP clinic. There will always be a rural hospital nearby. So I think like in the exam questions, you get that you are in a rural hospital and the nearest tertiary hospital is 4 hours away. There are GP clinic, which is like this, like even in the nearest 4 hours, there is no rural hospital. There are GP clinic in the remote areas as well. But in exam, most of the time, they would not ask you to go for a streptokinase in a GP clinic because giving a streptokinase needs a lot of expertise. Patient can go into cardiovascular shock after giving the streptokinase. So generally, idea would not be go for a streptokinase in a GP clinic, but if that is the scenario in the exam, you will need to save the patient anyway, and you need to take that risk. Okay. Here everyone about this case, because we did discuss this one in our class, both as a face-to-face and online, it should be okay, I guess. Thank you, Dr. Farhana. Any myocardial infarction, Dr. Maria, should be decided by the cardiologist, any management that you do, except the monotherapy, which you will be able to do, but anything else has to be done by a cardiologist. So always involve the cardiologist in this situation. STMI, non-STMI, same. Any questions? No, good question. The time period of giving a streptokinase, reteplase, or alteplase, any of the fibrinolytic drug, is within 12 hours of onset of symptom. If there is no pain, obviously we will not go for morphine or nitroglycerin because these are mainly given for pain. Yeah, the 4.5 hours is for a stroke, not for myocardial infarction. Okay, all good, guys. So let's do another role play and then we can finish. Who wants to do the last one? That's why they would not give that to you, Dr. Mariam. Non-ST elevated MI will not be given in the exam because you can't diagnose non-ST elevated MI with just pain. Okay, so it's very unusual to give it in the exam. The idea would be if a patient has got chest pain, which has a cardiac history, like a cardiac pattern of chest pain, even if the ECG is normal, you'll need to straight away order the troponin. And troponin should be repeated if initial one is normal. ECG should be repeated if initial one is normal. So by the time when troponin comes, then only you can treat them. So you'll need to keep the patient under observation, do this troponin, and only when troponin comes, then you can manage. Non-ST elevated MI, the management is more or less same. Just in this case, you don't need to send the patient urgently to the catheter lab. So you first find out if it is a non-ST elevated MI, and then obviously mono treatment will be started initially, even without the troponin elevation, because you are thinking this might be a heart attack. So morphine, aspirin, oxygen, nitroglycerin, those will be your step. And once you know that this patient has got non-ST elevated MI, you can start the patient with heparin. So heparin will prevent further clot formation. And usually, ideally, within 48 hours, this patient needs to go for coronary angiogram for further management. Most of the time, they will either have a stent put in or angioplasty. Sorry, or a bypass graft. So a stent or bypass. In palpitation case, can we ask for ECG in the beginning? No, you can't. Only time you can ask it if in the stem it's written that the ECG is given. Dr. Faril, yes, you can do the last case. Please unmute.
Hello, doctor. How are you doing?
I'm good. How are you?
I'm good, thank you.
Okay, I'll give you the case just in a bit.
Sure.
So this is your case. You have 1 minute to start.
Yes, doctor, I can start. May I know the patient's name?
Okay. Just 1 second. So yes, so this is your patient. Your patient name is Sam. You can start.
Sam, yeah?
Yeah.
Should I start?
Yeah, so just let me give you time again. Yeah, so start.
Sorry. Hello, Sam. I'm Prayal, one of the doctors present here in the clinic. How are you doing?
I'm good, doctor. Thank you.
Sam, so I understand from the notes that you've been having some squeezing type of chest pain for past 2 hours. Is that right?
Yes, doctor.
I'm extremely sorry to hear that. Are you in any pain right now?
Yeah, I'm in a bit of pain.
Oh, sorry, Sam. So let me assure you, you're in a safe place now as you've come in time, and I'm here to help you. I'll arrange some painkillers for you. Are you allergic to any of the painkillers?
No.
That's good. I'll arrange, and while the painkiller kicks in, I would like to ask you further that about this pain. Would that be okay, Sam?
Yeah, sure.
Sam, can you tell me more about this pain?
Yeah, there is kind of like a squeezing, burning pain that I've been getting for the last 2 hours.
Mm-hmm. And have you had this pain before as well?
Yeah, I've been getting this for the last 6 months.
Mm-hmm. And have all these episodes been similar or any difference in them?
More or less same.
Hmm. And when exactly these pain episodes occur? Are you doing any activity or at rest?
It can happen at any time, even with rest.
Oh, I'm so sorry to hear that. And does these episodes have any relation with the food?
Yes, I think like, especially when I go to some Indian restaurant and have some spicy
Mm-hmm.
food, most of the time I get it.
I understand that. And usually these episodes happen after that, after you consume any spicy food and you feel any burning then.
Yeah,
Sam, any nausea and vomiting with these episodes?
no,
And can you please point to the exact site of the pain?
it's in the middle of my chest.
And what is usually the intensity of these pains on a scale of 1 being the least and 10 being the most?
Usually 4 to 5.
And what is the duration of these episodes usually?
It usually lasts for 2 to 3 hours.
I'm sorry to hear that. And does this pain go anywhere else?
No,
And is there anything that makes the pain better?
no,
Is there anything else that makes the pain worse?
yeah, usually after lying down.
I understand that. And is there any deep breathing making the pain worse?
No,
Any coughing making the pain worse?
no,
Sam, did you had any flu-like illness before?
no,
Any fever or runny nose right now?
no,
Any coughing or sneezing?
no,
Any trauma to the chest?
no,
And did you have been taking any painkillers recently?
no, doctor.
Any medical conditions I should be aware of?
No, doctor.
Do you happen to have any over-the-counter medications?
No,
Have you tried anything else for this pain, like milk or anything that relieves it?
no,
Any medical history in you or in your family of heart diseases?
no,
Did you recently travel anywhere?
no,
Any calf pain or tenderness?
no,
And do you have been having any uh, fever or changes in your weather patterns?
no, doctor.
Do you have any tummy pain besides that?
No,
That okay.
no,
And uh, what about your poo and pee?
it's good.
Sam, do you smoke?
No, doctor.
And what about alcohol?
Occasional.
And do you take tea or coffee?
Just as usual, doctor. Not that much.
How is your usual? How many cups usually?
2 to 3.
That's okay. And have you have any other allergies so far?
No.
Thank you for the information, Sam. I would like to examine you now with your permission and explain the findings to the examiner. Sorry. So I would like to allow examiner to ask the investigation from examiner. So examiner, for my patient Sam, a 50-year-old man, I would like to do some investigations like full blood examination, ESRs, urea electrolyte, creatinine, any lipid profile, blood sugar levels present, HbA1c, liver function test, renal function test present. I would also like to have a ECG. All right. Thank you, examiner. So, Sam, after asking you all those questions and having your investigations with me, I've got a graph that is called electrocardiogram that charts the electrical conductivity of your heart. I'm sorry for using lots of medical jargons. Let me explain it to you to make it simple. So, this electrocardiogram charts your electrical activity, showing what's happening in your heart, and in all the it and all the different parts of the ECG points out towards a different part of your heart activity. But in their case, I can see are the P waves are present, the rate is fine, the rhythm is fine, but there are some ST elevations present in almost all parts of the leads. That points towards the condition called pericarditis. I'm sorry that you have this condition and you're in so much pain, but let me assure you that it can be managed perfectly. So what happens, there is some inflammation of your heart that is causing that, and it might be triggered by any of the infections that you might have recently. Are you getting me so far, Sam?
Yes, doctor.
So, and what happens when there is inflammation in the outer lining of your heart? This is causing the chest pain and all the trouble that you're having, especially on lying down. So, don't worry, we can manage it effectively with painkillers and some bed rest. Other things that I was thinking about was GERD, a
Time
gastroesophageal
out.
reflux disease.
Thank you.
That
Thank you, Dr. Farrell. It's good, very good. I think like you're doing really nice and good. Everything is
Thank you,
fine,
doctor.
history, investigations. Now let's come to the ECG. Where is the ST elevation?
Yeah. I see the LC elevation a bit of in lead 1, in lead V1, V2, V3, AVF, a bit of AVL. I thought so.
Oh, no. Okay, so let's have a look. So this is the V1, that's your isoelectric line. ST wave is good,
Hmm.
okay? V2, not good. V3 good,
Hmm.
V4 good, V5 normal, V6 normal.
Oh,
Coming to the lead 1, everything is good. V2,
it's a
look,
normal
lead 2, if you
ECG.
say like, yeah, it's a normal ECG. So
Yes.
that's actually
And
the
they're
trick.
just
It's
tricking
a tricky
us.
one.
Yeah, it's a trick.
Yeah. So you
Yeah, now I
have to just
realize
say
it's
everything is
actually,
normal.
yes,
What's the
it's actually
case?
gastroesophageal reflux disease. Yes.
Yeah, it is. Because everything you have got from the history, right? Like everything. So the spicy food, the lying
Yes.
down makes it worse. So that thing is like, that's what I actually said initially, that don't think that always the same case we do in the course or class that will come in the exam. This is how the exam cases actually come. So they trick you with many things. So it looks like squeezing pain, 50-year-old having an ECG. It should be either pericarditis or MI, right? But the case is just a normal ECG with a gastroesophageal reflux. Okay, so everything
Yes.
is good, but if you say it's a pericarditis, they will fail
Yes.
you. So
Initially,
that's the
initially,
unfortunate
Dr.
thing.
Ashan, initially I did understand it's gastroesophageal reflexes. I don't know what happened after seeing the ECG.
Yeah, I was thinking like to stop you because I thought you already got it. But
No, it's
then at the end,
okay.
when you said it's a pericarditis, I
Yeah.
felt like,
No,
no,
it's good that I will
no.
learn from my mistake and others will learn from my mistake as well now.
Yeah, that's it. You did good. So you're
Thank you
doing
so
really
much.
good. Just keep on the nice track.
Thank you.
Yeah, thank you.
Hmm.
Okay, guys, so as you can see that this can happen with any of you. I'm sure like most of you would do the same mistake, but that's how it is. So anything can appear in the exam. It just like you will always need to know that you already know everything. You just need to correlate everything in the exam and keep your mind broad. Just don't think that, well, Dr. Arshan discussed MI and pericarditis in the class, nothing else will come in my exam. It's never like that. Anything can come. That's why we do the differential diagnosis, because those differential diagnoses, any of them can pop up in the exam, and you will always need to include those things. Okay. So in this case, how should we explain ECG to the examiner? Same like we have discussed, Dr. Maria, in the class, that you discuss the P wave, QRS complex, rate rhythm, just like we did in the class. Yes, Dr. Shobi, even everything is fine and the diagnosis is wrong, the case will be failed most likely, because it's all about making the right diagnosis. Acute gastritis instead of gastroesophageal reflux, I would rather say it's reflux, because burning chest pain, if Dr. Farid would ask me that Do you feel like there is acidic or metallic taste in the mouth? Do you think that sometimes your mouth gets filled with saliva? Then I would say yes. So it will be a reflux case if she asks more questions about reflux. It's not, I would not say gastritis, esophagitis as a diagnosis, because there is no specific way to diagnose esophagitis and gastritis just by the history. Reflux, you can always diagnose by history. Esophagitis, gastritis, usually diagnosed after you have done an endoscopy, and endoscopy results shows that. Then you can diagnose them with that. But otherwise, as a symptomatic way, we can either diagnose them as reflux or peptic ulcer disease. Dr. Mariam, we will always go for focused history. In exam, if we want to go for everything like 50-year-old, we should talk about bowel cancer screening, no need. That's not actually the case. Patient came to you with a chest pain, focus on the chest pain only, at least for the part of the exam. In real life scenario, yes, we will do it, but not even on the same occasion. Once, if a patient comes with a particular history or particular complaint, we try to manage that first. Once that is managed, then if we have some time, we go for those screening questions. Peptic ulcer patient will have epigastric pain, and the pain will be constant pain, and pain happens after eating food. They will not give you a reflux-like symptom like burning chest pain and then having mouth filled with saliva, metallic taste or acidic taste in the mouth. So that's usually not the case. Type of chest pain is always important. Like squeezing chest pain this is actually not a very good type of chest pain that we get in reflux. Patient can have a misperception of their pain. So we can't just be focusing on their type of chest pain. It's as a whole, we will make the diagnosis. Squeezing and burning. When I said burning, the case became reflux at that time, because burning pain never ever is a pericarditis pain or heart attack pain. I can see that many of you are asking questions from what we have already discussed in the class. So if you guys have missed the class, like the class 1 and class 2 on cardiology, that's the reason why you're asking these questions now, I guess. Please go through those classes because we did discuss about most of these questions you are asking. There is a case with bleeding. So the bleeding case, I think like there was only once it came. So we normally don't go for that type of like infrequent cases. So the bleeding case can be like, there is a case with angina with anemia. So patient will come to you with chest pain, and this will go on for months and months. And when you ask about it, you will get that usually patient having all the chest pain, like chest pain gets worse with exertion, better with rest. So it's the angina kind of pain. And you'll find out that patient, when you did the physical exam, on parectal exam, you will find patient having some rectal bleeding. Okay, so if a patient has parectal bleeding with angina, the likely reason that you might also be able to find out that patient is having a bleeding peptic ulcer, which is causing this melena. And because of excessive bleeding, patients losing blood from the body, which is causing this angina. So we call it angina due to anemia because of loss of blood from the stool. Okay. But for this kind of cases, like obviously, if a chest pain goes on for months and months, yes, we should ask for, because this patient can have a peptic ulcer disease as well. So we will obviously ask about the peptic ulcer disease questions like Dr. Faril asked about painkiller, which is important. A lot of patients can take NSAIDs for a long time, which can cause peptic ulcer. We should also ask about bowel habit, any blood in the stool. Those will come into those discussion. We discussed this peptic ulcer gastroesophageal reflux in our GIT class. So that's why I'm not going in that much detail today. It will be discussed in the course. And don't bother with that sawtooth. Even if you see it in lead 1 or AVL, we should always look on the whole scenarios, especially in the lead 2. Okay, there are a little bit of like a wavy pattern in here, but ECG it's something which you should perceive based on the history of the patient and also as a whole, not just a single lead. Perforated peptic ulcer cannot be diagnosed just by history, right, Dr. Maria? So you will need to also examine the patient, and then you need to do an investigations, then to confirm. Again, we don't discuss GIT in our CVS cluster. When we will have our GIT class, please ask these questions. All right, everyone. So that's it for tonight. I hope you learned how the cages can appear in your exam, and also like how much tricky it can be in your exam. So it's not all about just learning the theory. It's also about doing these cages with your partner so that the way of your talking change over time. If you think that right now the way you are doing role play, if it stays same even in the next 2 months, that means you did not learn anything, or you did not do the role play with your partners. So the reason we do these role play classes is to show you how the cages come and how the role play should be done. And you can see that some of you did really a good role play today. You can learn from them as well, like how they are talking, how calm they are. And based on that, you can also improve your approach. So do this, and any of them who has done really good today, they haven't just done it today. They have been preparing as well. So you as a beginner, you don't need to think that why I can't be like that. It's not like that. When they were in your position, they were also doing like yours, but they did role play over the time. They improved themselves, and that's what you should do as well. Okay. All right. So that should be all for tonight, guys. Thank you, everyone. Have a good night. Take care.